Good afternoon, everyone. Happy Wednesday lunch. We're waiting as folks trickle in through the Zoom corridor. We're so happy to have everyone here today. So we're excited today to offer this next installment of the Gender Equity Education Series here at the Lerner College of Medicine. This is an effort to bring topics around gender equity to the forefront, and the hope is that you'll go back into your own departments and continue these conversations with your colleagues. Today we have Dr. Jasmyne Jackson, who joins us from Boston Medical Center to talk about intersectionality in medicine, a very important topic. But before we get to Dr. Jackson's presentation, I want to acknowledge Dean Page, who's a great supporter of gender equity, who is coming to us from the home of his brand new grandson in Washington, D.C. So thanks for making the time, and congratulations to you and to your family, Dean Page.
Thanks very much, Dr. Doherty. Everyone, this is little James. He was born 8 days ago. I'm greeting you from my daughter and son-in-law's basement, where my wife and I are here kind of helping out with this one and our 2-year-old. I wouldn't miss this event. So what I want to do is just acknowledge Dr. Doherty for all of her efforts, the importance of this topic, my gratitude to those of you who are attending, and especially for having gotten to meet just briefly Dr. Jackson, who's going to be speaking with us. For obvious reasons, I'm going to go on mute, but James and I are going to be listening in with interest, and we're starting him young in understanding the importance of the topic at hand. So greetings to everybody.
Thank you so much, Dean Page. And we're excited to have James as our newest member of the male allyship group. So without further ado, I want to introduce our special guest today for our Faces of Gender Equity portion. What we've been doing over the last few sessions is bringing in community members to talk about gender equity in their sphere of influence, and to talk about their perceptions, their attitudes, and what they're doing to move the gender equity agenda forward. And today we have the privilege of hearing from Dr. Elizabeth Bonney. Dr. Bonney is a tenured professor of obstetrics, gynecology, and reproductive sciences here at the Lerner College of Medicine. She has been the division head for reproductive sciences for quite some time, and leads a robust research program that focuses on preterm birth and immunology in the maternal fetal system, but also touches on issues like mentorship. And she's quite active with some of our student groups, pre-medical and university level students in mentorship. And it's my honor to have Dr. Bonney speak with us for a couple of moments today. Dr. Bonney?
Well, hello to everyone in the audience, and welcome to little James, and to everybody who is an ally in what I'm hoping is a disruption of a system. The speaker today, who I acknowledge is a very accomplished woman, and you'll hear more about it, wrote a paper where she described a viral illness. We have a systemic viral illness in the blood, in the water, in the very bricks and mortar of our society. And its source is a foundational ideology that a single group of human beings, which happens to be identified as white, cisgendered, heterosexual, monotheistic, and male, is superior to all others. And this group's recognition, praise, support, comfort, well-being, success is more important and of a higher priority than all other groups. And this is where intersectionality starts. The very life, liberty, mental health, physical health, professional success of individuals and all other groups is critically dependent on the ability to support this one group and align with its goals and this foundational ideology. And while the rest of society is grappling with this issue, academic medicine and science lag behind. And what is this foundational ideology is at baseline and under usual or normal circumstances, people of color, gender minorities just don't possess the intellect, the creativity, the judgment, the emotional or psychological stability, the moral compass, the sense of humor, and many other important traits needed to be good doctors and scientists. And in short, this ideology says we don't belong here. And what this means is that in academic medicine and science, there's a system and a culture through which everything we do, say, and think are put through a tainted lens. Those of us who are visionary and innovative are seen as being impractical. The expression of a high pedagogic standard becomes bossiness or directiveness. Assertiveness is seen as confrontational. Professionalism is seen as lacking in emotional intelligence. Hardworking is seen as being lacking in perspective. A prioritization of self-care and health is seen as being lazy. Aspirational issues are seen as being egotistical. Success is denigrated. Passion is seen as being lack of professionalism and bullying. And in the past 2 years, I've learned that none of this at the root has changed. And what has changed has been an increase in the complexity and the entrenchment of the protections that support the system as it is. And just yesterday morning, between sign out and grand rounds, I had reminders of how this system works. Systemic racism, sexism, is more than an act of emotional or physical violence. The microaggression, the slight, the oversight, etc. It's the ideology that it's okay for people who are in minority status to experience these acts. It's the ideology that those committing these acts are reasonable. They have a reasonable rationale. They should not be called out. They should be brought in. They're basically good people. They are driven by an inherent unconscious bias that's not their fault. It is the ideology that makes those of us who defend ourselves being seen as inappropriate, ourselves unprofessional, or lacking in communication skills, thereby negating both the criticism and us as human beings. So both the system and its underlying ideology need to be broken. And as you sit here and listen to the following speech and any other speakers, what you need to focus on, what you need to come up with in your mind is the commitment, those discrete small and large steps, the ways and approaches, and the means and resources to break the system. And I really welcome it and have great hope for young people, accomplished people like our next speaker, and for all of you who are involved in this process. Thank you very much.
Thank you, Dr. Bonnie, so much for those very powerful and heartfelt words, and for really challenging folks to examine the world around them, both in big ways and small ways, and understand how their perspective is shaping how they interact with the world around them, and affecting other people. And I want to challenge all of us to be disruptive and to be critical in this way, and not be afraid to give voice to it. So thank you very much, Dr. Bonnie. I'm going to hand off to Dr. Holterman now, who's going to introduce our guest speaker for today.
Thank you all for your powerful words so far. We are really happy to welcome Dr. Jasmyne Jackson to LCOM and our Gender Equity Education Series for her presentation, The Doctor is Out, Intersectionality in Medicine. Dr. Jackson is a senior pediatric resident at Boston Children's Hospital and Boston Medical Center, where she is in the Urban Health and Advocacy track. She is a 3-time Wolverine, earning her BS, MD, and MBA, all from the University of Michigan. With past roles in school-based health, quality improvement, managed care strategy, and curriculum development, she aims to contribute innovative strategies that will sustainably center equity within healthcare in our communities. Upon residency graduation, she will begin fellowship in pediatric emergency medicine at Brown University Hasbro Children's Hospital. With that, I'll turn it over to Dr. Jackson. Thank you.
Thank you all so much for this opportunity. I'm just going to share my screen. All right. Wow, Dr. Bonnie, that got me fired up. So I'm so excited to be speaking with you all. And thank you to the Gender Equity Education Series at Lerner College of Medicine for this opportunity. I have no financial disclosures. I am, however, a lifelong learner, and there are different topics being covered, and I'm still learning and growing, and I'll be speaking from my perspective, and I want to recognize that people dedicate their careers to gender equity, humanities and medicine, LGBTQ affirming care, and anti-racism work, and I appreciate and look up to those that are continuing to push these fields forward, and I also am full of hope for what the next stage of medicine can look like. For our objectives, I want to review intersectionality as a framework for conceptualizing how a person, group of people are affected by systemic advantages and disadvantages, examine our own identities and how they influence interactions with learners, coworkers, and patients, and discover strategies that can improve inclusion within the learning environment. I ask that you all participate both in some of the activities and in the discussion to help facilitate these objectives. The principled space was originally developed by artist and activist Helene Ramos. A principled space recognizes that it is never truly possible to guarantee a safe space, and thus in its place, I hope that we can commit to adhering to a set of agreed upon principles. The first is we will actively engage respectively with the aim of understanding others' views and experiences. We will trust that people are always doing the best they can. We remember the learnings while respecting confidentiality. We will avoid blaming or shaming, and we will embrace discomfort. For some materials, just need a paper and pen, doesn't need to be too fancy, and let's jump into things. So as Dr. Bonnie stated, I first wrote a piece that came out in JAMA Pediatrics in October of 2020, and I really wanted to circle back to what prompted me to write. And this means taking back to June 2020. I was near the end of my intern year in this pandemic, and what a whirlwind of like just learning where the hospital is in relation to moving to a new city, to figuring out how to put in orders, to feeling so nervous as a new pediatrician about even just writing for Tylenol, and figuring out how to be the best doctor for the patient in front of me, while we're also staring this unknown pandemic in the face. I can remember distinctly hearing that in my home state of Michigan, that is about 13 to 14% Black folks made up 40% of COVID deaths. In March, my parents, both of them who live in the Detroit area, also got COVID and thankfully did not have that outcome. But I remember seeing this story feel oh so familiar with how in medicine, due to systemic racism, people of color die more. And my dad was worried about me as a new doctor and asked if I even had PPE. And so I sent him this picture just to give him proof that I was lucky enough to have some. And then at the same time in June 2020, there was a continued murder of Black people by police and medical institutions publicly recognizing their role in systemic racism. I remember feeling tired of Black folk dying by both of these viruses that Dr. Bonnie alluded to, racism and COVID alike. And this demonstration at Boston Medical Center, right afterward, we left there feeling struck by finally we're acknowledging something that's been going on for centuries. At the same time, my co-resident helped me find a small park for my wedding right after that. And so our wedding was supposed to be in Michigan. We made the decision, like many, to prioritize public health and cancel. So during Pride Month, June 2020, we had a small ceremony in a small park with a small number of masked friends. And it was the perfect day. But having a pandemic, systemic racism, and police violence, a wedding as a queer person to my now wife, I just felt that I was in a case of emotions, that there was a lot going on. I was trying to compartmentalize everything. Okay, I'm a doctor over here. I'm a new wife over here. I'm a Black person over here. I'm a woman over here. And I was just trying to survive. And it was just strangely unsettling as all these boxes were starting to spill over into each other. And before combustion, I needed to have some time for critical reflection. What am I feeling? I need to identify my emotions and then try to analyze them. Is this a pattern? Because maybe if it is, then it could have a name. And am I alone in feeling this way? That compartmentalization is not a way for survival. It is not a way for me to thrive. And would other benefit from me identifying what is happening? And so what I was experiencing was truly this collision of identities. A new doctor in a new pandemic, trying my best to be flexible, being afraid for my patients, being afraid for my coworkers, I'm afraid for my community. And then in 2020, we're still in the fight for Black lives, seeing that time after time as a descendant of ancestors who were enslaved, that racism is still killing Black fathers, Black mothers, taking Black children, killing Black trans folks, friends, and partners. We have Breonna Taylor on March 13th, killed by the Louisville police. George Floyd, May 25th, Minneapolis police. Tony McDade, May 27th, a Black trans man killed by Tallahassee police. And then at the same time, I'm also celebrating a day that I never dreamed of, a day that I was brave enough to love who I truly am out loud, and that my love was recognized by friends, by families, and even the law. A level of acceptance that as a teenager, I thought was out of my reach, and a level of acceptance that I felt that so many of my queer identifying patients longed for, especially now as anti-LGBTQ legislation is sweeping across the nation in a dangerously violent way. So then that next stage was to think about, have I felt like this before? What is the pattern? And it brought me back to summer 2015, where on June 17th, we had the Charleston church shooting where 9 Black people were killed during Bible study at Emmanuel AME Church. And then on the 25th, another joyous moment where we had Obergefell versus Hodge, a landmark civil rights case, which the Supreme Court of the United States ruled fundamental right to marry is guaranteed to same-sex couples by due process and equal protection of the 14th Amendment. And then on this roller coaster again with July 15th, Alton Sterling, July 6th, Philando Castile, and then the tragic death of Sandra Bland after an unlawful traffic stop. And this is a quote from my paper, where I felt the visceral and unsolicited reminders of the fragility of Black life. That omnipresent fragility sparked my interest in pediatrics to help communities heal, especially those affected by structural violence, and strikingly uptick in acceptance, or at least recognition, sparked my interest in coming out. And so what it led me to is then the how. What we're seeing is tragedy. What I'm also experiencing is triumph. How are both of these possible at the same time? How can there both be pain and pride, violence and victory? And what I discovered was compartmentalization was a disservice to the complexity of my experience. And intersectionality gave me a method for processing. The term is coined by Dr. Kimberly Crenshaw in 1989, a UCLA law professor and critical race theorist, originally designed to discuss the identities of someone being both Black and a woman. And I think that she explains it best in her TED Talk, The Urgency of Intersectionality. And let's cross our fingers that audio is on our side today.
So what do you call being impacted by multiple forces and then abandoned to fend for yourself? Intersectionality seemed to do it for me. I would go on to learn that African American women, like other women of color, like other socially marginalized people all over the world, were facing all kinds of dilemmas and challenges as a consequence of intersectionality, intersections of race and gender, of heterosexism, transphobia, xenophobia, ableism. All of these social dynamics come together and create challenges that are sometimes quite unique.
I literally had a thought in 2020, right after marriage, like, am I allowed to be happy at the same time as all this is going on? How can I recognize, acknowledge, and honor the struggle for civil rights still in this country, and also recognize how far I have come as a queer person in accepting myself and advocating for my patients and being out. And I think the framework of intersectionality allows for all these things to be possible. It can be both, it can be and intersectionality has central tenets that I would like to go over next. The first is understanding that the patterns of discrimination are interlocking, and they cannot be separated one from another by only one aspect of an identity or experience. So if I am experiencing racism as a Black woman, I can't just separate it out and say that I'm only experiencing racism just as a Black person, but then how does sexism also tie into it? And how does my privilege of being cisgender also tie into it? The next tenet is that identities need to be examined in the context of power dynamics. There's an interrelationship between identities, must be understood in the context of the social institutions that create power differentials between said identities. And lastly, that there are real unique strengths of identities. And so despite originally being created to analyze and address a deficit mindset or an oppression mindset, intersectionality lens can also reveal unique strengths of marginalized communities and resiliency in different communities, and can present opportunities when properly understood and appreciated that may be employed to enhance things like public health, to create more strength-based approach to focusing on health outcomes and health issues that have plagued us for a number of years. The next step of the how is just to get some basic definitions down. So as we discussed, intersectionality is the examination of identities and how their combination influences how we experience the world. When we discuss racism, I like using Dr. Kamara Jones' definition: a system of structuring opportunity and assigning value based on social interpretation of how one looks that unfairly and disadvantages some individuals and communities and unfairly advantages others. And then for heterosexism, the assumption that all people are or should be heterosexual. Heterosexism excludes the needs, concerns, and life experiences of lesbian, gay, bisexual, and queer folk. While it gives advantages to heterosexual people, it reinforces the realities of silence and invisibility. And so now that we've discussed what intersectionality is, how I came to really embrace it during times of triumph and times of tribulation, I next want to talk about some tools for how we can forward intersectionality in healthcare. And I think number one is acknowledging our identities without assumptions. And so for that, it was my coming out journey. When the legalization of gay marriage empowered me, I was terrified. In 2015, I was like, this is gonna be my moment to embrace my true self, to tell my parents. But as a only child, I was afraid of what that would look like for them, of them mourning the life that they thought that I would have, of the advantages of being a heterosexual person in America. And I remember before I could even get the words out, I was sitting in the passenger side of my dad's car, and I just started crying because I knew what was coming, and that my image, his image of me may change forever. And he was like, whatever you tell me, it's okay. Like, I love you. And it took me 10 minutes to find the words, and it was uncomfortable, but I was so proud of myself and so proud of the eventual outcome. And in this narrative that I wrote, I say that coming out to my mom, and her main thing was that she was scared for my safety, and that she thought that I'd be harassed as a queer person. And me also having to recognize that as a cisgendered, femme-presenting woman, I have a lot of protections that other folks may not have. However, as a Black person, I was like, Mom, I'm more likely to be targeted because of my race than for being queer. And that's that intersectionality at work, that thinking about what are your systemic advantages and disadvantages and how they play together. Of course, in your roles as a healthcare provider, but then also in your personal life, your ability to just to walk around the street without being worried of being targeted. And I felt that, for me, I had felt so much growth in my personal life, but also felt that after coming out to my parents, I was not out to my coworkers, I was not out to my patients. That heteronormativity of medicine was still threatening that freedom that I was finally experiencing, that took me decades to cultivate. Homosexuality was only removed from the DSM in 1973, and medicine's heteronormativity is reflected in the number of times I've still asked and have to correct my colleagues that I have a wife, not a husband, reflected in parental leave policies and insurance coverage for family planning. But seeing my personal growth and understanding what it meant to celebrate my true identities means I had to use my voice to start the conversation of how do we do better by our intersecting identities, and how do we bring more into the healthcare workforce to therefore advocate for marginalized communities and then our patients. And so the personal motivated me to be a freer version of myself. And I would like for us to finally use that pen and paper that I asked folks to get out. And I want you all to draw a circle, because we're talking about the personal. We really need to look at our identities. And it's typical that we can list off the things in the categories that we belong to or don't belong to. I think really writing them down and seeing them in front of us and seeing different ones next to each other can be powerful. And so you can draw a circle in the middle of your paper, and I have listed some ideas of different identities that you can list off in your circle. And then I will give you next a example of mine that I've done. So I put that I am Black, a US citizen, I'm in my 30s, I live in Boston, I have natural hair, I'm able-bodied, I'm a woman, I'm cisgendered, I'm queer, I'm a doctor, middle-class upbringing, from Michigan, I'm Christian, English is a first language, then I have an additional M.B.A. And now it is your turn. And so there's your reminder, there's your circle. Let's see if my elevator music is gonna work for us. I'll give you all a couple minutes to do this. I do not own the rights to this music. I feel like I have to say that, so Jill Scott does not. Is that a thumbs up if that was enough time? Okay, great. So I want you to hold on to that piece of paper. We will come back to that. The next thing is that we talked about recognizing our identities without assumptions. And I think that without assumptions portion is really critical, because not everyone that belongs to the same group is a monolith. And I think one way to think about this is really focusing on what are our values. And so values and being aware of what values we hold, how do those enter into our workspace? How do those enter into the different identities that we have laid out and how they intersect with one another? And for me, the 4 values that I've listed out here is authenticity. A family mantra of mine is for us to thine own self be true. And so being your truest self, it took me a long time to get there, and it's still something that I'm working on. But that is definitely a value. Bring compassion in how we create a world in which everyone can be their truest selves and be loved because of who they are and not despite it. How do we create a culture in medicine where healthcare workers can bring their truest selves to honor those identities that are on that sheet of paper, and honor and value those differences and have those differences be recognized? For example, can we talk about having anxiety and depression at work? Can we talk about having a child with special needs? Can we talk about being divorced, being a single parent? All those identities influence our personal lives, and why is it that there has to be this sterile divide between who we are as people and who we're supposed to be within the walls of the hospital, which is all rooted in those systemic issues that Dr. Bonnie laid out earlier. And then connection. How do we build relationships with our patients? How do we relate? How do we swallow our fear to be relatable? And then finally, last value that I aim to bring in is justice, bringing awareness to the unique circumstances of individuals. How do we center at the margins? How do we create a system where people have agency because they have everything it takes to meet their basic needs and beyond that? And so with identifying those identities and then also honoring those identities, we also have to think about what values we hold within those. And so like you all, somewhere on that paper, could be in the top corner, is reflect on what 2 values you bring into work and why. And if people want to use the chat, I think I'll be able to maybe see. People want to put in the chat what their 2 values are. And if you need to put 3 because you can't pick between just 2, that's also okay. All right, we have honesty and compassion, authenticity and community, beautiful. Curiosity and courage, curiosity, honesty, respect. Teamwork and open-mindedness. I think all of these are remarkably important because you can literally tie each one of the values that are listed into intersectionality. So teamwork, we have to honor each other's identities and bring an intersectional frame to work better as a team. And so that we are honoring honoring each other's differences and not trying to make people fit into what has stereotypically been a good doctor. We have to work with open-mindedness if we're not understanding someone's communication style and seeing what their past experiences have been. We have to bring forth a curiosity and an honesty and a respect to identities that are different than us. And so with that, with recognizing these identities, with thinking about values and how they turn and tie into intersectionality, we have to recognize power differentials. And so if we recall our circle, we can go back to it and circle which identities have historical power and underline which identities have historical oppression. Yes, I can definitely repeat. So with that identity circle that we have from before, I want you all for each identity to then put a little baby circle around it of the ones that have historical power, and then underline which identities have historical oppression. So for example, I would then circle being cisgender, and I would underline being Black as an example of something that has historical oppression associated with it. I think this is important and something that I have to come back to, because we start getting comfortable in our identities, especially those that have power. In that narrative that I wrote at the end, I come out to a patient for the first time. And in that instance, I had to remind myself of the power differential. I am a doctor, I have my doctor hat on. There is an inherent power differential between patient and doctor. I am not a teenager, so there's an age differential, and that therefore has power associated with it. I'm in a different time, and at this, especially right now, when I'm talking to my patients that are LGBTQ identifying, I have to understand that I am coming also with a lot of privilege, being in this profession, being of this age, being now married and out to a family that's accepting, that may not be everyone's experiences, because there is no monolith. And so when I'm talking to a patient, especially right now, as there's so much anti-LGBTQ legislation, I can't just say like, oh, well, it just gets better. I have to acknowledge that as a doctor, as someone who's secure in my career, as someone who has come out, as someone who's from an accepting family, that these conversations are gonna look a little bit different, and really be critical in the words that I choose, the assumptions that I make when talking to a person that has one identity that aligns or is similar to mine. And then we can also reflect on, for the identities that have historical power, where do we see those playing out in our physical spaces in the hospital, whether that's what professors we see on the walls when we walk into lecture halls and there's a number of distinguished white men, whether that is the accessibility of different rooms in either the OR or in exam rooms, meetings, and just starting to reflect on where do we see these things inherently in our physical spaces of medicine, and therefore in our power structures within medicine. When we think about things like promotion, we think about things like retention. And that leads to tool number 3, to practice perspective taking. And so Mari Musada in the 1990s is a critical race theorist that challenged activists and those aiming to work in an equity-informed lens to start asking the other question, essentially to call attention to and recognize when interlocking forms of oppression are occurring, and not just focus on the main form that is most apparent. And so their quote goes, "When I see something that looks racist, I ask, where's the patriarchy in this? When I see something that looks sexist, I ask, where is the heterosexism in this? When I see something that looks homophobic, I ask, what are the class interests in this?" Because all these things, the systems of oppression are interlocking, identities are interlocking, and it's important to have that intersectional framework, so then we can point out what are the gaps and how can we do better by each other, by taking the other perspective, especially the perspectives that are most marginalized. And lastly, the last tool is to be authentic. I can remember as a medical student being taught professionalism, 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 and having that idea of professionalism being drilled into me. And when we think about what does it mean to be a professional, what characteristics are considered professional? And it doesn't mean that we can't be people. It doesn't mean that we can't be our real selves. I'll give an example. Ending residency also means ending my primary care clinic. And I have a family that I've known since their child was a newborn. His family's from Eastern Europe. We don't share the same first language. We don't share the same race. We don't share the same ethnicity, or citizenship or sexual orientation. This is the first time mom in the middle of the pandemic. I remember first meeting this family and how scared this mom was of being a first-time mom in a pandemic with no family near, and authentically listening and creating a connection across all of our differences on the surface. And now 2 years later, had the last meeting, well child check with this family, and the mom cried saying that told her that I was leaving and going on to fellowship because of that authentic connection that we shared by listening, honoring each other's differences, being real, not having to just fit into a box of what does a doctor look like, what does a doctor act like, and being vulnerable. And within that, it's also remembering our why. Why is intersectionality important? Why is it important to create more inclusive spaces? And it's literally lives are at risk if we do not. As a pediatrician, one of the things that I point to the most is the proportion of LGBTQ youth who reporting a past year suicide attempt. And this is by the Trevor Project in 2019. It's showing that for youth, there is more than a 1 in 10 chance that LGBTQ identifying youth have had a past year suicide attempt. And this number jumps to 30% when you're looking specifically at non-binary and transgender youth, thinking about that intersectionality approach. And then when you think about race as well, our indigenous teens or indigenous populations, those numbers are in the 30s for both cisgender and transgender folks. Thinking about a suicide attempt, a young person taking their own life or attempting to take their own life. And then when we think about discrimination, LGBTQ youth, 71% of them are experiencing discrimination. What happens when you tag onto that youth of color? What happens if you tag onto that folks who are from lower SES statuses and those identities impacting how young folk are experiencing the world? And then it even gets into how they are able to access healthcare. So this graph is also from the Trevor Project, and just looking at folks who are able to access mental health care overall, and then folks who have considered suicide who are able to access mental health care. And we are not capturing the folks that need to be captured. And if we look at, for Black LGBTQ youth, less than 40% of them are accessing healthcare, mental health care overall. And then when you're looking at Black youth who are LGBTQ who have also considered suicide, only 1 in 2 are having access to mental health care. And so this is my why of the importance of intersectionality, specifically thinking about our future, thinking about this is a life or death situation. And what's even more striking is only 30% of LGBTQ youth are out to their doctor in a time where there's nearly 240 anti-LGBTQ bills that are just filed in the first 4.5 months of 2022. And so with the legislation also tagging on to the discrimination and the hate and legislation that is attacking healthcare access, I'm expecting that the number of youth that come out, that think of healthcare as a safe place, is going to drastically decline. If you're thinking about Black trans teens who may not have the same access to healthcare or the same resources, all those intersections of oppression are truly life or death situations. And it even gets into our healthcare workforce and thinking about just articles that came over the last year or two. There's articles coming out of people leaving residency programs because they are not feeling welcomed in their identities, because their intersection of identities are not being honored. Black doctors leaving academic medicine in general, the lack of inclusion in nursing, the number of incidences of mistreatment around sexual orientation with medical students, and then even our clothing in operating rooms not allowing for folks who have different religious beliefs. And so we think back to our tools for intersectionality in healthcare, acknowledging identities without assumptions, recognizing power differentials, practicing perspective taking, and being authentic. I think that we can get to this goal of the Gender Equity Initiative, seeking to foster a care of equitable and just work environments for the benefits of all community members. And we can live up to those ideals that are the reasons that a lot of us joined the field of medicine and healthcare. And for a final thought, what is one thing that you all do within the next week to push forward intersectionality and inclusivity in your specific role? I think you have to put it in the Q&A since use the Q&A, please. And one thing that I started doing as a senior resident and supervising a team of interns and medical students was having a conversation about intersectionality in the beginning of the rotation. And I had this spiel that talks about, we all bring things into this workspace. I want to honor the identities that you have, the ones that are important to you. And within that, I want us to have a call in culture. So if I'm saying something that is offensive, if I'm not living up to the ideals of justice, equity, and compassion, then call me in, bring me in and say that, Jasmine, I noticed that you did this and this is how it made me feel, or this is how it could have made the patient feel. And let's just have a conversation, because I want us to be striving for those ideals. And that's something that I have incorporated when I'm working on a team of med students and learners. All right, and then we have some responses of bring this topic up for discussion to our staff meeting, question my assumptions and ask curious questions. We have someone who said, think about how decisions impact my colleagues at various points of potential intersectionality, not the one dimension I may assume. Question alternative areas of power differential when something comes up, like your example of asking about sexist power structures when thinking of racism, and try to be more cognizant of my own place of power and others' perspectives. And help others doing this work succeed, as always. Thank you, Dr. Bonnie. Awesome. All right, and that is my contact information. I do see that we had a couple of questions that we can open up, if that's okay with the other panelists.
Yeah, I think that's great. Dr. Jackson, thank you for spending your time here with us today. This has been a phenomenal session. I really like that you really had us think and spend time reflecting on our identities, things that are maybe prioritizing things. And, challenging us to use our particular identities that may be of power to help move forward towards social justice. It can be really challenging, right? I mean, we as taking our points of positions of power and trying to strive towards equity, we find ourselves in places where we can be vulnerable as well. And one of our participants here has a question for you. First, thank you for your thoughts on your authenticity and professionalism. But related to that, one of the values that this individual holds strongly is vulnerability.
Mhm.
As a child psychiatrist, often, however, vulnerability can lead to struggles related to compassion fatigue, and the balance can be hard to strike. Do you have any thoughts, or what do you do for yourself to avoid the descent into compassion fatigue and burnout?
Yeah, that is such a thoughtful question. And I think that is a balance that I've had to really explore throughout residency, especially the burnout portion of that, because the beauty of vulnerability is that you get to feel. And when those feelings become overwhelming, when they become depressing in some ways, then it can be difficult to then execute and do what you need to do to help continue the work that is so important. And I think one of the things that's been important for me in battling compassion fatigue is understanding when I need to take a break. And so when I need to lean on the others that are doing, if it's a project, a number of projects I work on with other residents that are centered in equity, having a community to say like, hey, can you step up to take this? Because I can only focus on like clinical work right now when it comes to those equity focused projects. I think when it comes to the day-to-day of clinical work and being with patients who are feeling so much of the issues that we laid out today, for me, what has been really powerful is having a therapist. I think therapy, especially for medical professionals, for folks who are helping, who want to honor people in their most vulnerable moments, having time to also reflect on how those moments are affecting you has been really critical for me. And I'm very privileged to have access to that as a resident and have my program encourage for everyone to have that. And I think it has been a great tool for me to just have a space to explore how some of those feelings are being transferred back to me, if I'm also honoring being vulnerable in sharing that.
Thank you. I think we have time for maybe one additional question if we have any from either the panelists or if anyone from the audience would like to submit anything in the chat. I will say that, I think I'm taking a lot of what you're saying in terms of leaning on individuals, right? Having a good support network as well as has been really helpful for me as well in terms of continuing this, because it is a marathon. It's something that we're not going to fix right away. It's not it's not a sprint, and it's a lifelong journey and adventure that we're on. And having a support group, the support network, has been critical.
Yeah. And I would love to hear from Dr. Bonnie as well, as a tenured professor, just about what strategies you have used for compassion fatigue and burnout.
Thanks for pointing to me, but I am really fatigued right now, having put in 2 NIH grants last week, and I'm on call this week. So compassion fatigue, I think, has to be with self-care. I mean, basically to prioritize the care of yourself. I mean, when you notice things are slipping, like your blood pressure is getting elevated or your weight is doing much or something like that, you got to take care of yourself, I think, first. But I did want to add one more point to this discussion, which I think you've touched on. It's really important, is that those elements of our identity that are powerful and how they might be used to oppress, and a position to oppress other people who also may be femme presenting, may be in our environment. So I think about doctors versus nurses. I think about white women versus black women. I think about cis versus trans. I mean, we all kind of femme presenting in some sort, but then those people and those positions of power can produce oppression in those around us. And so I think, professor versus student, all right? Those are things that we need to pay attention to as we think about intersectionality. And I really appreciate you, and I'm looking forward to more of your work.
Thank you so much, and congratulations on the grants. And I hope, fingers crossed.
Thank you so much, Dr. Jackson, for all of your words, for I think particularly for your vulnerability and your willingness to share a story with us about how you've moved through time and space. I think it's really poignant, and then giving a framework in which to think about it more broadly is powerful. I'm thinking now about when you raise the questions from Mari Matsuda about ways to incorporate questions like that into institutional decision making. You know, there are some healthcare institutions that will have like a question: how does this best serve the patient, right? And so every decision that's made, how does this best serve the patient? But I think that these other sorts of questions, how does this serve the patriarchy? Where is heterosexism in this? Might also be a way to bring this constant check back into conversation. So thank you so much for sharing that. I want to also just give some closing thoughts and thank yous. Thank you to Leanne Holterman and Joe Conant, who co-chair the Gender Equity Education and Professional Development Working Group, who spent a lot of time behind the scenes bringing these sorts of sessions to you. Tiffany Delaney, who's our director of ODEI, for unwavering support. Tammy Candido, who's our administrative coordinator and is seconds almost away from taking a new position. We wish her all the best in her future endeavors, and we've really enjoyed having her with us. Jordan, our captioner, Bruce Kimball, and the ComAV team, and of course, Dr. Jackson and Dr. Bonnie, our face of gender equity this morning. The next session of the Gender Equity Education Series is on May 2nd, and Dr. Ann Sumner, who's a section chief at NIH, will be talking about disability in medicine and science, continuing along this theme of intersectionality. So please join us for that May 2nd at the 12 to 1 hour. And also this talk will be posted. It's been recorded. It will be posted on the ODEI video library. Give us a couple of days to get it up. But please pass along to your colleagues who weren't able to attend the link to the recording. This is a really powerful talk. It's can be a difficult topic to talk about and to sort out and to sit with, for some of us more than others. And I just want to thank you for doing that. And I really encourage everyone to take a look at this recording. So thank you so much. It's the 1 o'clock hour. We're going to leave everyone, and we'll see you next time. Thank you.